The U-Learning is the platform of the educational platform of the IC Foundation, and really it's a great pleasure and an honor for us collaborate with IFSO in this symposium. Welcome everybody and enjoy this experience. Bye.
Thank you, Mariano.
Thank you.
Mariano, thank you very much. Thank you very much for this opportunity. I hope that it work out as well for us as it has for you. So, in a few minutes, we'll start our symposium. We're still waiting for a few others to sign on. It's good to see you, and for everyone, happy Thanksgiving from the United States.
Thank you. Same to you.
Thank you.
It's a very important holiday for us, and centered around family, and unfortunately, somewhat a bit of a gluttony as well. So appropriate that we're talking on this day, I think. Okay, so we're Professor Ramos and Jacques Kimpens and Mufi. We're still waiting for them to get their sign on.
If you want, Kelvin, we can have 5 more minutes to fix all the connections, and in 5 minutes we can start.
Sure, I think so. We'll give everyone a chance to come on board. You know, we have some really very good talks coming up. I'd hate for anyone to miss any of this. And I can see our attendees are signing on slowly but surely. We limited it to about 200 participants, and it filled up quite quickly. So I anticipate a pretty good turnout. Truly, this is a pretty good, and we're reaching around the globe. So Lillian, what time is it for you in Australia right now?
It's about 11:30 at night. Way past my bedtime, but I'm still awake.
Wow. For us, it's 5 in the morning. For Juan Antonio, too, it's 5 in the morning, right? Yeah, there you are. So we... Well, we appreciate everybody's efforts. I think that Central European time, it's around 2 o'clock p.m.
Well, regardless, it's a pleasure to be on and sharing this session with all of you.
Yeah. I think we can, we might be able to change the times around to make it more convenient regionally, and then we'll just get up a little bit earlier. You don't have to stay up so late, Lillian, and of course you were up at 1 in the morning the last time we talked, so I think maybe you're a night owl.
I'm getting used to this now. I don't need to sleep anymore.
Ah.
So I think Almino will start. Kelvin, is that right?
We have Juan Antonio starting. Is there a problem with your microphone? Yeah, I think so. He's muted. Well, the good thing about a video, we can do some sign language or something. Or maybe Nicholas has to unmute his microphone.
Nicolas, we need a microphone for Juan Antonio.
Okay, good morning. Can you hear me?
Yes, we can hear you.
Finally, 5 a.m. in the morning from Tijuana, Mexico. For everybody, happy Thanksgiving.
All right, well,
we celebrate Thanksgiving as well in Tijuana.
Okay. Okay, so why don't we go ahead and get started while some of us start signing on. I want to introduce you to the very first IFSO Virtual Learning Academy online symposium. For the topic, we chose a very interesting and very timely subject, the right procedure for the right patient. And the experts have come to you from around the world. We have several presenters. For discussants, we have Jacques Kimben from Belgium, Antonio Torres, Nathan Zandel, and Mufata Atwala. I'm hearing some music in the background. Are you all hearing the music?
Yes, we can hear that.
I'm not sure where the music is coming from, but it's not time to celebrate yet. Our first speaker is Juan Antonio Corvala, president of the Latin American chapter. Each of the presenters will have 10 minutes to talk, and then at the end we'll have time for questions and answers and some discussion. So welcome everybody to the future of distance learning. Juan Antonio is going to talk on multiple options. How can we help patients make the right choice? Juan Antonio, you have the floor, or in this case, a computer screen.
Okay. So the screen. Good morning. Can you see my presentation?
Perfect.
Yes.
Yes, we can.
I'm ready. I don't know if I can start.
We can see your presentation, Antonio.
Okay. Thank you very much. Very controversial topic, the right procedure for the right patients. My topic is to talk about multiple options, how we can help patients make the right choice. This is my hospital. I'm from Tijuana, Mexico. Thank you very much to share this presentation. And would be very important, after we complete patient evaluation and we confirm that the patient is candidate for surgery, how to help the patient to have the right to choose the right procedure. Would be important to talk with the patient to have real expectation. This would be important because if we want to reach goal, would be important to talk with the patient. Another point that would be important as well is to know what kind of patient do we have to choose the procedure. And remember, they are a preference group, preference surgery, that we need to talk about that. We recommend to have more than one option for the patient, and we recommend to perform as a surgeon more than one options. These are the procedures that have been accepted by IFSO. We know all of them. Adjustable gastric band, sleeve gastrectomy, gastric bypass, and biliopancreatic diversion, DS. This is the trend of the surgical procedure in the United States, but it's similar to our country and it's similar in most of the countries in the world. It would be important now that the most popular procedure now in the world is the sleeve gastrectomy, and this, with more than 50% in 2014. We estimate that now it's more than 60, maybe in Latin American countries, more than 70, maybe except Brazil. But in Europe, I think they have the same data. The second procedure is Roux-en-Y. In our country, maybe it's less than 20%, and only a few surgeons perform BPD. In the United States, it's less than 1%, and revisional surgery is increasing. In our experience, in our practice, in this moment, is more than 20%. When the patient is candidate for surgery, we need to evaluate what kind of patient do we have to choose the right procedure. Will be important, I told you, to reach the goal, to real expectation. What does the patient want? But it's important, what does the patient need? It would be important to reach the goal. For example, we need to take in consideration different points. Age, for example, and we talk about adolescents, with some of the report talk about maturity bone, physiological maturity. We recommend in that group, what the report says about restrictive procedure is the most popular procedure. Another example, and we talk about patients over 65 years old. Remember, expectation life of this group and expectation weight loss is less. We don't need that patients lose, for example, 70%, 60%. I think in that group, most of the time, we need to choose restrictive procedure as well. To talk about BMI would be important. This is important. Low BMI and high BMI, remember, involved in some cases high-risk patients like super obese, super obese. We need to decide what is better for the patient according all these kind of points. If you talk about, for example, metabolic disease, in case of diabetes, there is no question. In this moment, the best option is a combined procedure like a gastric bypass. And another point that is important to talk, remember, more than 20% of the patients, they have acid reflux. I'm talking about obese patients. But when the patient has severe reflux or Barrett esophagus, the only option, in our opinion, in most of the reports, is gastric bypass. Would be important surgical group experience. I say, as a surgical group, we need to have more than 2 or 3 options according for what kind of patient do we have. Would be important the evaluation of the multidisciplinary group, because according with the evaluation, we will decide as well what is better for the patient. If you talk about revisional surgery, we need to be in the correct hospital with all the facility for that kind of patient. We are going to talk about some of the procedure. For example, when do we recommend the adjustable silicone gastric band? What do the reports say? Well, it can be a good option for adolescents. We were talking about restricted procedure for this group. According with the bone maturity, according with the physiological maturity. Another option can be all patients, because the expectation is different. It's low, the expectation, and we don't want to have major risk for this kind of group. For high-risk patients, can be an option for some group. Remember, this procedure in the world, every day they have less preference. This is true, but I think we need to work with some patients with this kind of procedure. And low morbidity, 30 to 35 with BMI, 30 to 35 with comorbidity. In the United States, it's an option as well. FDA approved this kind of patients for this surgical procedure. Would be very important if the patient choose with the doctor lab band the follow-up. We need to have maybe the best patient for this kind of procedure. And some patients say, finally, doctor, I don't want resection of my digestive tract. A band can be an option. When we don't recommend to do this kind of procedure, severe acid reflux, when the patient cannot do the correct follow-up, and no question about allergy to the material. We talk about sleeve gastrectomy. When it's important to recommend, according with the world experience, according with our own experience, well, adolescent can be a good option. Remember, not malabsorption procedure for this kind of group. All patients, because some of them, they are very high risk, is another option. Low BMI as well. High BMI, because this patient can be a very high patient. We need to evaluate, because the sleeve gastrectomy, remember, in this moment is the most popular procedure. And liver disease, as a cirrhosis, can be a good option. The possibility to have complication and decrease. And this is important when we talk about high-risk patient and when we talk about reductional surgery. First step of another procedure like a BPD or gastric bypass. When we don't recommend this procedure, severe acid reflux, giant hiatal hernia, and Barrett's esophagus. There is no question about this contraindication because this procedure can increase the acid reflux. Gastric bypass, in my opinion, is the most important procedure. Has decreased in the last years in my country and in other countries as well, but there is no question that the best option for this kind of procedure, when the patient has metabolic disease. This is important to explain the patient that can be the best option for diabetes mellitus or metabolic disease. And the only procedure for severe gastroesophageal reflux and Barrett esophagus, in our own opinion, and most of the report, is the gastric bypass. I think this procedure can be for most of the patients, but remember, there are another option that we need to choose sometimes. When we don't recommend the gastric bypass, teenagers, we were talking about bone maturity, very high-risk patients, because in very high-risk patients, when you perform combined procedure, can increase the complication. Inflammatory bowel diseases, we don't recommend. There are a lot of reports regarding possibility to have complications. And remember, severe abdominal adhesion, we need to evaluate and is according with the experience with the surgeons. Okay, the last procedure, remember, surgeon preference is less than 1%, BPD. It's a good option. I think it's a very good option, but we perform this procedure only in revisional surgery with as a last procedure, as a last option, and the second stage of the sleeve gastrectomy. Maybe most of the surgeons don't perform this kind of procedure. One of the points can be maybe the learning curve. Okay, would be important when we talk about, when we work with the patient about what is better for the patient in this disease, is to work with the real expectation, to work with the patient, what kind of expectation to reach the goal will be important. And don't forget, after surgery, we need to have education. Education involves to have a new lifestyle, and because we have physical activity, changes in eating habits, and behavior modification. I think as a surgical group, with the multidisciplinary group, we need to have more than one option for the patient. We need to explain everything regarding what kind of patient do we have and regarding what kind of goal do we have. Thank you very much. I don't know if you have questions.
Thank you very much for a great summary. But before we move on to the next speaker, I just can you give us just a 2-minute summary how when patients come to see you and they have a preconceived idea of maybe what they want, how do you handle this? Maybe you don't agree with what they want.
Yeah, it's important. What does the patient want, but what does the patient need? It would be important if you talk about, for example, diabetes mellitus. We need to explain the patients. We need to talk about result. We need to talk about complications. Would be important. Both to decide the procedure, and we need to explain the patient because sometimes it's incorrect to do what does the patient want, because we need to explain what is better for her health, what is better for her future in case of a woman patient. It would be important to explain the patient complication, to explain the patient results.
Great. Okay. Very good. Our next speaker is Lillian Cao, President of the Asian Pacific Chapter, and our topic is appropriate. When do you recommend the adjustable gastric band, or is this only the patient choice? Lillian, welcome, and thank you again for joining us so late in your day.
Thank you, Kelvin. It's my pleasure to be on this session, and it's also my privilege. Now, can anyone see my slides?
We have your screen.
Okay, you have my slides? You can see it?
Not yet. We just have your screen.
Okay, I've got my slides on.
You might have to mirror your presentation.
Okay.
There you are.
Okay.
We have you now.
All right. Well, I've been asked to talk about this probably because Australia has been gastric ban country for many, many years, but we are also finding that the gastric ban is decreasing in terms of popularity. Before I talk about the topic, I would like to address what would be considered an ideal bariatric operation. Patients come and they ask, what is the best operation? And patients do look at the data, and I think the ideal bariatric operation should fit these criteria. Firstly, it should be minimally invasive. Certainly in this day and age, we do offer the laparoscopic or the endoscopic or robotic approach. The operation should also be efficacious for weight loss and also to help their comorbidities. And of course, it should be a safe operation. The operation we give these patients should also be as physiological as possible, and we try not to alter the anatomy because it does affect their nutrition in the long term. If possible, we would offer minimal foreign material, as patients do react to foreign material in their body. Again, if possible, it should also be potentially reversible and also cost-effective. So how does the gastric band fit this? Gastric band has a number of strengths and therefore it has been popular for many years. It is certainly considered the safest bariatric operation. It offers a minimally invasive approach. It has been associated with the lowest morbidity and mortality, and in many centers can be done as a day case procedure. The gastric band has been around for 20-odd years and has been shown to be effective and durable. It is a controllable device. It allows adjustability to the patient, and also, when removed, is considered fully reversible. I think if looked after well, the gastric band is associated with a low reoperation and revision rate. However, the gastric band also has some weaknesses. I believe it allows an initial slower weight loss, and this can be an advantage or disadvantage depending on the expectation of the patient. The gastric band is indeed a foreign material. It consists of silicon with a titanium velocity port, and this can be a disadvantage. To look after gastric band patients, we do require skilled and regular aftercare, and it can be fairly intensive. If patients don't follow the rules, there are side effects such as reflux and vomiting and obstructive symptoms. There are some complication rate. It has been associated with slippage, pouch dilatation, erosion, and also port site access problems. If you look at the complication rate of bariatric procedures in this particular paper, which was published in Surgical Endoscopy, looking at the various complication rates, you see here that the adjustable band has a fairly low complication rate compared to the bigger operations such as the Roux-en-Y gastric bypass or the BPD. In this particular paper by Paul O'Brien in the British Journal of Surgery, where he looked at a systematic review of patients or studies with more than 10 years of follow-up. There were 9 for the Roux-en-Y gastric bypass, for the gastric band, 7, BPD 4, and a large number of patients in each cohort. And if you look at the perioperative mortality, the gastric band is certainly the safest of the 3 groups of operation. The follow-up achieved was also very good. But if you look at revisional procedures in this group, it's a high variety ranging from 8 to 60% for the gastric band, Roux-en-Y gastric bypass 8 to 38%. There was not available data on the BPD for revisional surgery. So if you look at gastric band revision statistics in the literature, there is a marked variability ranging from 8 to 60%. If you look at the 3 recent studies, the labs in the USA looking at 610 patients, there was 17.5 events per 100 patients over 3 years. And this include band removal, revision to another bariatric operation, or port revision. In the O'Brien study of over 1,300 patients, it was 15.3 events per 100 patients over 3 years. Keating also published in JAMA on the Australian cohort looking at 2-year data by what we call the medical benefits schedule code, which means all patients that are registered on the Australian benefit codes. They found a very similar number of 18.9 events per 100 patients over 3 years for revision. So it's fairly similar right throughout these 3 studies in terms of revision statistics. O'Brien also looked at the revisional procedures in his cohort of patients over an 18-year period. And what he found was that with the development of the technique and the evolution of the technique, erosions, revisions decrease over time with experience. In my own unit, where we looked at our 1,000 patients, particularly in the past flacida technique patients cohort, find that on the right-hand side, our revision rates are fairly compatible with what is reported. It would be considered a low revision rate for our gastric band patients. So, as far as bariatric surgery is concerned, I think when patients come, they need to be aware of the limitations of bariatric surgery. We as surgeons need to know that obesity is a chronic disease. Treatment of this disease is therefore lifelong. We need to be aware that a single operation will not remain effective in the long term. If you look at the data from bariatric surgery, there is a revisional rate for all bariatric operations. Whether it's a stapling operation or a band operation, there is a revision or reoperation rate. Gastric band is no different. It began in the early 1990s. There are key changes have occurred in the band design, the surgical placement from the perigastric to pars flacida technique, and therefore it's still evolution in its design and technique. The technique itself, if you can see, has changed from the band being initially starting as a high pressure band. It's now become a low pressure band. Some of the balloons have become non-creasing at higher volumes. Even the site of placement of the band has changed from the lower gastroesophageal junction to now being accepted as a virtual pouch. It's now recommended that we repair the diaphragmatic hernia. The initial perigastric technique has now conformed to a pars flacida technique, and even with the placement of the port, it has changed from within the anterior rectus to probably anterior of rectus muscle. So the question is, who should have an adjustable gastric band? Well, I believe any patient who meets the criteria for bariatric surgery should consider this option. However, these should be to well-motivated patients who are committed to regular aftercare and for patients who prefer an unaltered anatomy. Like all bariatric operations, they should be offered to emotionally stable patients who are not dependent on drugs or alcohol. And more importantly, patients also need to be in close proximity to their bariatric clinic. As a rule now in Australia, we do not offer the gastric band to patients from the country or what I consider more than 100 kilometers away from our clinic. Again, if we give gastric banding to these patients, we will find that some patients will still struggle with their weight loss. We need to explore their behavioral and psychological issues to help them with their weight loss. And we also need to instigate good eating habits in these patients. Over more recently, we've also advocated repair of the hiatus hernia to help their reflux symptoms. And we do find that when complications such as erosion and slippage that occur, we can treat them quite successfully. I think I'll stop there, and we'll take any questions if any would like to ask me.
Okay, I think we can save the questions toward the end, so we can kind of encompass all the different speakers and the topics. Our next speaker needs no introduction. John Morton, past president of the ASMBS and current chapter of the president of the North American chapter, and he's going to talk about all things being equal. How can we decide between the sleeve and the gastric bypass? Certainly very appropriate to our neck of the woods. John, are you on board?
I am on board, Kelvin. I don't know if everybody can see my slides up.
Let's see if we get a slide up. And happy Thanksgiving.
To you too. We do have a lot to be thankful for, like technology and friends. So, can you see me, Kelvin?
We got your slides. Excellent.
Okay, great. Well, good morning, everybody, and I want to congratulate Kelvin and Manuel on getting this virtual learning academy off the ground. It's a great idea, and it shows what we can do when we work together. And already a bunch of terrific talks this morning, and I'm going to talk just very shortly about deciding between the sleeve gastrectomy and the bypass. And I think a few things we have to take into consideration are when deciding about any sort of operation is looking at safety, looking at efficacy, taking into account some of the patient concerns, because I think that's become more and more important, and finally looking at mechanism and see that impact that it can have. One thing we have to realize is that we've done a terrific job when it comes to mortality over time, and you can see that in the slide here, that we've dropped our mortality by 10-fold in less than 10 years. It's pretty remarkable, because if you look at other fields of surgery, you don't see the same effect. It's pretty much only in bariatric surgery that you've seen this rapid decline in mortality. Now, some of the reasons why you might see this decline in mortality, because these are U.S. data, is likely because of accreditation, but it can also be because of fellowship training, and it can also be because of choice of surgery. All of those things have probably played a role in why you see improvements in mortality. Now, in deciding which procedure, I put here a very basic framework. This is my approach, and I'm sure others have their approaches as well, but a couple of things to consider. At least here at Stanford, our sleeve and bypass patients stay 1 or 2 days. We scope everybody before we operate on them. So if in our practice, if they have grade C esophagitis or higher, or Barrett's or any other stigmata of reflux, we generally don't do the sleeve on those patients and prefer the bypass. If they have bad diabetes, meaning taking insulin, having diabetes for more than 5 years, then we generally approach them towards, again, a bypass. Now, for the larger BMIs, we do prefer the bypass because they get, at least in our hands, more weight loss long term, and I'll show you that in just a moment. However, there are specific circumstances where the sleeve is superior to the bypass, and that is if you have patients who are going to require medications long term, there's most likely better absorption with the sleeve. And that includes some of your joint patients that might need Motrin or other NSAIDs. Inflammatory bowel disease, you know, that's a soft contraindication against a bypass. Well, some of us have done patients who have quiescent Crohn's, where it's not necessary to avoid a bypass, but in general, the sleeve can be a good option for those patients. The other one is prior abdominal surgery, particularly hernias. I don't have that listed there, but that's another one to think about. One that doesn't come up as often are kidney stones. If they have a long-term history of kidney stones, the bypass could potentially make that worse because of oxalate. Finally, bypass, as I've already listed there, it seems it does help better if you have bad reflux, diabetes, or if you're looking for longer-term weight loss. This is a slide I presented at Obesity Week just a couple of weeks ago in New Orleans, and what we demonstrated there was the impact that a decreasing readmissions project can have on readmissions. But I thought it'd be interesting to take a look at a couple of things here. One is if you look at the morbidity rate, this is complications. You can see the bypass is roughly about 4%, but the sleeve morbidity is almost half that, if not more, at 1.87, 1.27. Length of stay, you can see here, is shorter for the sleeve than it is for the bypass, as you can see there. This is bypass and this is sleeve, as you can see. And the other thing that we saw here is that the readmissions don't change for the bypass, but they did change for the sleeve. So this is just one component of safety, if you will, with the two procedures. And these are big data. There are over 60,000 cases being performed here. One other thing to consider here is, deciding between the sleeve and the bypass is obviously the big elephant in the room, the one that people are concerned about, is that there could be potential worsening of reflux. Many people don't agree with this for one reason. If there were a lot of problems with reflux, we would have seen it by now because there are so many sleeves being performed. But here are some of the reasons why you can see increases in reflux after a sleeve. I think the biggest one there is the shape of the sleeve. If you have a corkscrew shaped sleeve, you can increase some of the risk for reflux. The other thing, of course, is any sort of hiatal hernia that needs to get addressed. I'm not sure if Jacques is on the call, but just wanted to point out the study that he did a few years ago demonstrating that reflux went up when patients regained their weight over time. So this may be something that we see later, and you can see that demonstrated in his study there. Good correlation between weight regain and reflux. Well, the other thing to consider here if you're looking at both procedures is around the impact it can have on efficacy, meaning on safety. I think there's good data to support the sleeve as being safer than the bypass, at least based on population level. Here's a study I think that many of us view as being quite instructive when it looks at bariatric surgery versus medical outcomes, but also the difference between bypass and sleeve. I do want to say one thing about the Stampede trial that you guys can see here. The majority of these patients were BMIs under 45, the vast majority of them. So this is really for smaller, grade 1, grade 2 type patients. If you look at this next slide, it shows the different procedures. You can see sleeve gastrectomy, bypass. This is looking at hemoglobin A1C and then medical therapy. Clearly surgery is better than medical therapy. And if you look between the two of them, at least at 3 years, you can see that the hemoglobin A1C is pretty close. And here you can also see the use of diabetes medication. Bypass is a bit better. And then finally, when it comes to weight loss, bypass is better than sleeve. Again, not a huge difference, but a significant one. On the next slide, you can see a couple of things that I think are interesting. One is the number of medications that patients are taking following the procedure. You can see here very few of the bypass patients at 3 years are taking it. A bit more are taking it with the sleeve. And then if you look also at any medications at all, you can see a pretty big difference. So again, it just shows the demonstration. Long term, what we see when it comes to weight loss with these two procedures. This is some data from our institution that we have published this year. And what we looked at were biochemical cardiac risk factors. Blue is bypass, the orange is sleeve, and the band is green. And you can see there pretty much across the board that the bypass does provide superior results. And this is 1-year data that we have since shown all the way out to 7 years. But you can see here what a big difference the different procedures have. One to orient you to is C-reactive protein, which is a marker of inflammation, which is a good predictor of cardiac risk. And in our patients who are obese, we're starting to realize that obesity is truly a disease of inflammation, and it's the cause of so many of the different comorbidities we see, everything from diabetes to sleep apnea, even cancer. And you can see there that with the bypass, you get a very good reduction in C-reactive protein, almost 70%, and that's different from the other procedures. One other one to look at here is triglyceride over HDL ratio. And what this is a marker for metabolic syndrome. And you can see there that they're fairly close, the sleeve and the bypass, but still a little bit better for the bypass. On the next slide, this just shows what happened when we took into account the differences of the patients who present for surgery, because we know that the sleeve patients can be different. They can be smaller, less comorbid, but when we did the regression analysis, what we found here was that there was a substantial improvement for C-reactive protein that was more than double than what you see with the sleeve. On the next slide, you can see the improvement in triglyceride HDL ratio. Again, a big improvement for both bypass and sleeve, with the sleeve being with the bypass being a little bit better. So in conclusion, we can see that there's improvement in the cardiac risk factors, particularly for the bypass. That's unique. I do want to close on one topic that actually Lillian brought up, which is around the fact that obesity is a chronic disease and that most likely a lot of these patients might require some sort of revision down the road. These are data that demonstrate how much the sleeve gastrectomy has grown over time. Now the bypass has declined, but the other one to look at here is how much revisions have gone up. And that is an important point because revising a gastric bypass is not trivial. There aren't great answers for it. Lengthening, stoma reduction, all of those are sometimes not always seen with the best results. We also know any sort of revision carries more risk and less efficacy. I always like to say revisions are never as good as the first time as a primary procedure, and that's something that we've shown. Here's a study that we have coming out that we had come out this year, where we show that what matters is not necessarily the type of procedure, but the BMI that you start from. This looks at the impact that the starting BMI has, and obviously the lower the BMI, the better weight loss you're going to have long term. And what we really need is earlier referral for these patients and downstaging of the BMI, meaning the lower the BMI we have, the better results we have. Just like cancer surgeons have better results with stage 1 than stage 4 cancer, we're going to have better results with stage 1 obesity than we are with stage 4 obesity. And there is a lot of heterogeneity to weight loss. We looked at this in our group as well and wanted to see if there were differences between bypass and sleeve. And this just shows a demonstration of that. If you look at the left-hand column here, this is bypass, the middle column is sleeve. And then you can see here that that one thing that's obvious is how consistent the weight loss is for the bypass, and it has that bell-shaped curve. If you look at the sleeve, it does not have that bell-shaped curve. It has a shift to the left, if you will. And of course, the band has got a great deal more variation than all of them put together there. If you can see here in this one slide, what we do show is, if you will, success or failure rates for them, and then you can see them at 12 months as well as at 24 months. And you can see here that the vast majority of the bypass patients, even out at all the way up to 5 years here, have a very low, if you will, failure rate, meaning less than 35%. It's only 2%, and that's different from the sleeve, which was at 21%. So long term, you can see these changes are significant between the two procedures in terms of weight loss. Now, this includes all comers. It doesn't distinguish based on BMI. Final point I'll make here is around patient preference. This is a survey we did in the United States that got some coverage in the New York Times not too long ago. A couple of things to point out here is that people in the United States do view obesity as being a big problem. In fact, it's tied with cancer. It shows that people consider it to be something that's of great concern. The one big thing that comes up is around safety. And there are still patients that don't feel bariatric surgery is safe, even though I showed you the mortality rate is 1 out of 1,000. So there's still a lot of concern in that direction, and I think that is what guides a lot of patient choices. So in conclusion, both procedures are going to be safe and effective. We do need more comparative trials. We have to take into account patients' preferences, though I think we're surgeons. We need to give them our best advice. And many times I have talked to patients about the sleeve may not be the best option for them because of their diabetes or reflux or because of their weight. And we do have to consider that some of these cases will be revised. So thanks to Kelvin and everybody for the opportunity to present today, and wish everybody a very happy Thanksgiving.
Thanks a lot, John. That was fantastic. I'm really enjoying this venue. Everyone's been timely, and the presentations have been fantastic. Now, I may be moderating this symposium, but really the credit really belongs to Almino Ramos, our next speaker. Almino is the current treasurer of IFSO, but he really brought this to the forefront and was spearheading this symposium. And so I want to welcome Dr. Ramos for this idea, the implementation, and for his next talk about duodenal switch. Should everyone offer the switch, or should this be a procedure just for specialized centers? Welcome, Amino.
Thank you so much. Let's show my slides that tell me if you have my slides.
Yeah, we see your slides.
Okay. Congratulations. I think that we have the privilege to see a very nice session, and I think that I can link my presentation with the presentation that John just showed us, because I agree 100% with him regarding that BMI is something very important. It's a reference in order to choose the correct procedure for our patients. But the question we have to answer here is, should everyone offer the duodenal switch, or should this procedure only be done in specialized centers? So this is the procedure. I think that we agree that duodenal switch is the best bariatric and metabolic procedure with the best weight loss, very nice long-term weight loss maintains, is the powerful procedure to remission of diabetes, and is very important in terms of control of metabolic syndrome. But even with this information, if we look for the numbers of duodenal switch all over the world, will be very depressing, because as you can see, we have an average of only 1.5% of the surgeons all over the world using duodenal switch. If we look for the data that also John presented to us, we see the numbers of ASMBS, and duodenal switch is less than 1%. In the last report is 0.6%. If we look to the Brazilian data, we will see that duodenal switch here in Brazil is about 2% of our bariatric operations. So we have the question, why with this huge good data about duodenal switch, surgeons are not using this procedure very frequent? And I think the main reason, I think that is really the surgeons are afraid regarding duodenal switch, afraid regarding the skills, the difficulty of the procedure, the intraoperative complications, the mortality. This is the procedure that we have the higher mortality among our bariatric procedures. But even though this mortality, it's about less than 2%, so it's not too high. But we have early complications. Yeah?
I mean, I'm sorry. Can you go to full screen on your presentation so we can see it a little bit bigger?
Okay.
Okay. Thank you. Thank you.
Thank you. So the reasons for this is that surgeons are really afraid about the duodenal switch. Using the full screen, I cannot move. Any problem, Nicolas? Because I cannot move my presentation.
Okay, then go back.
Okay. Lost the picture.
Yeah, we lost the slides now. Did we lose? Did we lose? We lost Amino altogether? Okay. Yeah. All right. Let's see if we can get him back online. In the meantime, let's kind of talk about the duodenal switch procedure. Jacques, you're here. Why do you think that the switch is not that popular in the world?
I think the main reason is the bad press of the procedure. I think most people are significantly afraid of the long-term outcomes, and I'm sorry, and they think that there may be issues in terms of minerals, calcium especially, and also nutritional deficiencies. I think that's the main reason.
Okay.
I don't think it's that much the difficulty.
Okay.
I'll be back. Let's try the screen once again. Do you have my screen?
Yeah, you got it.
Yeah, we have you now.
Okay, so let's continue. So the reason that surgeons are not using duodenal switch so frequently, in my opinion, is afraid of complications, afraid of the difficulty regarding the procedure.
No, we lost your audio now.
Yeah. What's happening?
Your audio is cutting in and out. I think there must be a gremlin in the system or something. Oh, we lost Amino again. I think this is. He must be in Brazil. I think this is the famous Brazilian IT system.
Yeah.
We're getting hacked.
Let's talk. Let's explore this a little bit more. So I think Jack, you bring up a good point about the SADI, or the single anastomosis duodenal switch. You think this is going to drive more patients, more surgeons to offer this?
I can only tell you that in the recent 6 months or so, the procedure has become really much more popular thanks to the SADI. And in Holland and in Belgium, but especially in Holland, all that people talk about is the SADI. So I expect there will be a sharp increase in numbers thanks to the SADI.
You think it's just because it's a new procedure and that there's some interest in this, or there's really about
the internet has been talking a lot about that, and people tend to follow that. You know, in the chat groups and stuff, they SADI is all over the place.
Right. So Mufi, are you there? Mufi, are you there?
Right.
No. Oh, wait a second.
Kelvin?
Amino.
Kelvin?
Yes. Yeah, Amino.
Do you have my screen now?
Yeah, we don't have your screen. We see your picture, though.
Okay, so let's try my screen. So,
let's see if we can get Amino's screenshot on.
Tell me if you have. Show my screen. Show my screen.
Good. There you are.
Okay.
Right. Okay.
But I cannot move my screen. It's not working.
It's not working? Okay. Well,
it's not moving.
Let's see if we can get. See if we can do some work on Amino's screen. In the meantime, I see Antonio Torres has joined us. Antonio, you there?
Yeah, I'm here.
Okay. Well, we're working out the technical issues with Dr. Ramos's presentation. Are you ready to tell us about well, you just kind of touched on the one anastomosis bypass and
Yeah, I'm ready.
And CD, yes?
Yeah, I'm ready.
All right. Now, Mio, you're not off the hook, though. We still need to hear the rest of what your thing is, okay? Okay.
I'm showing my screen now, Kelvin.
Yeah,
I have said to show my screen.
Yeah. Okay, we see the screen. If you can go to full screen, can you go to full screen and then we'll start.
Yeah. Let me a little bit. I think full screen. Can you see now?
Yes. Excellent.
Good. Can I go forward?
Yes. You are on.
Okay. So, well, the topic I have to talk is that do we really need new procedure like one anastomosis gastric bypass or single anastomosis with a sleeve, or the standard one we have are enough? Well, it's a very tough issue, as all of you can understand. And so when I don't know how to, I'm sorry, how can I
maybe use the right arrow? How about using the right arrow button?
Right arrow button on my computer, you said?
At the bottom of your screen. Try them.
Oh, the screen, on the screen, okay. Let me see, I cannot see.
Left, lower, or
bottom left screen?
Where the arrow is?
Bottom left.
What can I cannot pass, you know, my slides.
Yeah.
What can what do you have to do?
Yeah. How about using the right arrow button on the keyboard?
Okay, click the arrow.
Oh, now here? Yeah, I did, but now I cannot. I use the right button to go into, and but I cannot pass. No.
Antonio, try the button on the keyboard, the right and left button on the keyboard.
On the computer.
My keyboard, right?
Yeah.
No, I did.
It's not working, huh?
No, it's not working. My computer is not working.
Okay. I think this is the same problem Almino had. Why don't you come off of full screen, go back on come out of full screen, push your escape button, and then we can, you can just show the full screen again. It seems to be working better that way, huh? So
okay, I step back. No,
you're frozen. Okay.
My screen. My problem is I cannot pass through the slides.
Okay. Well, let's go back. Almino, is your system working, Almino? Can we go back to your presentation?
We can try.
Okay, let's switch back to Almino. Antonio, maybe you can come out of the full screen, and then we'll try you again. Almino,
now I can do that now. Can you hear me now?
We can hear you.
Can you hear me?
Yeah. If you're ready, Almino, let's go with you. Okay.
I can. Okay.
We have Almino's screen right now, so.
I think we have the same problem. I cannot move my screen.
I can move now. You can see my screen. I can pass the slide now.
Let's go back to Antonio.
Can you see my screen?
Not yet. Let's switch over to Dr. Torres' screen, okay?
Do you have it?
It's coming. We just have to wait a little bit.
Kelvin, you asking me something?
No, but again, when I got the connection.
There you are. Antonio, you're on again.
Yeah, I am on again, but as soon as, the system incorporates my full screen, I cannot pass through the slides.
Okay. I think this is what, tell you what. So, Antonio, we're not going to be able to use the slides, right? So I'm just going to ask you a few questions that, so what is the big deal, right? This is a very controversial subject. 1 anastomosis, 2 anastomosis. Are you, with your studies and with others publishing on this, are you ready to just give up 2 anastomosis and say the standard should be a single anastomosis, whether it's a duodenal switch or a gastric bypass?
My point is, Kelvin, that at present time, answering the main challenging question is if do we need something more? I think we need, in some special cases, like the very overweight patient and the very metabolic patient, and now at present time, in those patients with failed sleep. These 3 group of patients are going to be very important in the future to deal with them. So in this situation, there is no doubt that something more than a gastric bypass is going to be necessary regarding getting an ideal or almost ideal weight loss, almost ideal control of the comorbidities of the patient, first of all, type 2 diabetes mellitus, and dyslipidemic profile of those patients.
Okay.
So regarding to choose which malabsorptive procedure can you choose, or a standard BPD, a standard DS, 1 anastomosis gastric bypass, or 1 anastomosis duodenal switch, I think we have to investigate more deeply on that. But I think SADIS is showing until now a very nice approach. Now I can. Can you do that? Can you see that, my presentation?
Yeah, yes.
Yeah?
Yes,
okay, so this is my idea. Can I go through?
Yeah. Yes, please, quickly though.
Okay, perfect. So this is, the message I like to now I can control everything. Perfect. Here you can see, the numbers of the SMBA, showing that more than 50% of the patients are under sleep coming from 17 in 2011. It's going to be, in my opinion, a huge problem in the next years. Again, we have to define what is the success, as we mentioned. If we expect that we're going to be to lose much of 50% of the weight loss, going to be important on other parameters, but we are taking into account are going to be present, or we have to redefine our success definition. And so I think it's important to this new proposal or put this simple modification of the standard procedure we have until now. Answering the question I asked you previously, is it necessary to introduce a novel malabsorptive bariatric surgery procedure? I will try to answer this question at the end of my presentation. As you can see, there is no doubt that I mentioned that in the meta-analysis advantage review performed by Henry Buchwald, BPDDS is going to be better than the gastric bypass regarding the control of type 2 diabetes. And in this study that all of you know about the Gertrude Migroni and Fletcher Rubino published recently, the updating 5 years in this study comparing BPD versus Roux-en-Y is going to be very clear that regarding the control of the lipidemic profile and even in decreasing the number of the necessity of medication is going to be much better in this kind of patient. Again, the trial performed by the Swedish colleagues published in JAMA last year, showing us that the DS, standard DS, is going to be showing much good result 5 years after the operation that the standard one-way gastric bypass. It's the classic figure from Mark Bersler for New York, showing as the time goes by, especially in the overweight patient over 50 of BMI are gaining weight, as the time goes by. And this is the idea of our studies, to have something more metabolic than the standard gastric bypass and something less malabsorptive than the standard DS. This is a figure from our friend Catano Argentino from Brazil, showing us what is the sense of doing studies. It's going to be to have a wider sleeve, not too much restriction, only one anastomosis, maintaining the pyros in place, and being very versatile in terms of the distance from the ilosecond valve. You can choose 200 in the very heavy patient, 250, or 200 or 300. If you want to be safer and controlling, having more metabolic effect and none a lot of weight loss. And at the beginning, when we were designing the procedure, I think we thought that the procedure wouldn't work. Why? Because we were the same alimentary channel and 2.5 to 5 times for the common limb. So we thought that the study procedure wouldn't work, but it wasn't not true. This is our follow-up. I used to take that 8% of follow-up a year. It's going to be important in terms of knowing what is happening with these patients submitted to malabsorptive procedure. And here you can see, as I mentioned before, in very overweight patient BMI more than 50, studies is much better regarding the set weight loss 5 years after surgery. Here you can see also 5 years of surgery, this one anastomosis DS can say that. One anastomosis DS are going to be getting a very nice result regarding the glycemic control and the dyslipidemic control of this patient. What about the one anastomosis gastric bypass? Of course, this is another malabsorptive procedure. Here you can see a picture from Wei Li, showing a very long pouch and one anastomosis counting from the trace angle. It's going to be not very convenient, in my opinion, to do that without knowing the common channel in malabsorptive procedure. Here you can see a summary of the different results published regarding one anastomosis gastric bypass. compared with wrong way, has shown with efficacy and safety and very low morbidity with a high rate control of type 2 diabetes. But, you know, anyway, there is some concern about that. So, answering the question you asked me, Calvin, is it necessary to introduce a new one anastomosis DS or one anastomosis gastric path? My answer would be yes. We have to, you know, to move forward the statement recently published by the SMBS regarding the loop DS SADIS procedure, saying that this is investigational. That is a very strong word to say that it's investigational. We are working on that. Many people are working on that, and we have to continue to do this work. And in this sense, we are now finishing the inclusion criteria, comparing a standard DS with one anastomosis DS in 2 countries, Spain and Portugal, you know, with Jordi Pujol and Amador in Barcelona, Andres and myself in Madrid, and Mario Nora and Ana Marta Pereira in Porto, Portugal. And we already finished including the patient, and we see results in the next month or year. And I think it's a way of working, you know. Nobody, in my opinion, knows what will happen in the future. Now, here you can see some of the most important, you know, hard sentences said in all over the world. Look at this of Albert Einstein. There is not the slight indication that nuclear energy will ever be obtainable. Or look at this, Bill Davis. Look at this training program by IFSO, Web Scream. You know, in 1981, Bill Gates said that 400K would be enough memory for anyone. Look at this. And I also say that the phrase of paragraph of Arthur Schopenhauer almost 2 centuries ago, all truth runs through 3 states. First is ridiculized, second is violently opposed, and third state has been evaluated. So again, you know, as our president asks us, you know, don't forget to go to London next year to our annually IFSO World Congress. Thank you so much.
Thank you. Thank you very much, Antonio. And I apologize to everyone about some of the technical issues we have. And this is sort of to be expected, just as we are innovating with new procedures. This is, we can see this. Now, Dr. Ramos, I'm sorry we couldn't see the rest of your presentation, but let's cut to the chase. So the question is, it's not too controversial that the BPD-DS is perhaps the most effective metabolic operation. Diabetes, long-term weight management, but at a cost and a consequence. And it's a little more, it certainly is a little bit unfamiliar to many surgeons. For myself, as you know, we have trouble with long-term follow-up and patients being compliant. The question is, should this procedure be done in just specialized areas, or do you think for patients, they you know, as part of informed consent, that we should all be doing this operation?
I think that this procedure must be offered for experienced surgeons, for skilled surgeons, for surgeons with a previous experience in other bariatric procedures, as renal gastric bypass or sleeve gastrectomy, and in well-structured centers of excellence in bariatric surgery. I think that this is not a surgery for beginners. This is a procedure that, in order to achieve good results and avoid the problems, the complications of the surgery, we need a good preparation of the patient. We need a very skilled surgeons to do the procedure, and a very good multidisciplinary group to follow the patient after the procedure. But when we look for the data in the literature, at least the data we have right now, we are talking about a procedure with around 1 and 1 something mortality about 5% complication. So this is not high. I think that the surgeons that are doing duodenal switch right now, and we have very few, we could see that it's less than 2% of our surgeons. They have been doing a good job, because we are over time decreasing the complication, decreasing mortality, and I'm sure that we have, as Antonio said, we have to look, and John also, we have to look for another kind of procedures, at least for our super obese patients.
Hey, Dr. Latwala, Mofi, are you online now? Mofi, you there?
Yeah.
Okay. So very quick question. Diabetes is in the Asian countries is very important, and we need the most effective, most powerful diabetic procedures. Do you see the SADIs or the DS picking up at all, or are patients asking for this?
Hello, Kelvin. I'm back on.
Okay.
Kelvin, can you hear me? I'm back on.
Yes, we can hear you. Did you hear my question?
Yeah, I was. No, sorry, I was muted a second back.
Okay. No, so the question is, in Asia and India, diabetes is of course very prevalent, and the question is, how are you offering the DS or the SADIs to patients? Is it becoming more popular, or how does that incorporate into your algorithm on getting the right procedure for the right patient?
So as you can see, we deal with two issues. One is the obese diabetic, and one is the non-obese diabetic, or the low BMI diabetic. So when we're tackling a condition with the super obese, maybe the SADI is a good enough operation. But we have to, because most of the protein deficiencies that do take place in the long term. So if patients are not going to follow up, we are getting a lot of patients with protein deficiency, and that would be the same case as well with the single anastomosis gastric bypass, because if you are a surgeon who does not measure the complete length of the small bowel and goes on an anastomosis centimeter or more from the duodenojejunal junction, then there are a few patients who are presenting with a lot of protein deficiencies, a lot of diarrhea, at least in that region. We also have a procedure which is picking up in Asia, which is the sleeve gastrectomy with the duodenojejunal bypass. All right, so that adds another element to the SADS. So this is where we go away from the DJ flexure rather than from the IC.
Okay.
So
there are certainly there are even more options available than we have talked about here. And let's talk about the long-term issues. Again, the idea is, how do we counsel our patients into the right procedure? Michelle Suter, a question that John Morton presented. It was kind of interesting to see that the inflammatory markers are a little bit. There's an advantage of bypass over sleeve over a long period of time. And of course, we know what the long-term results of the bypass are from the Swedish obesity study, et cetera, reducing, increasing longevity and possibly reducing the risk of cancer and things like this. Is this something that maybe the sleeve may not be effective as the bypass long-term?
That's my belief. I think the more we move ahead and the more results we get, the more little signs, sometimes not big differences, but the more we hear that the bypass seems to be a little bit more effective in different aspects compared with the sleeve. It doesn't mean that the sleeve should not be done, but the patient should clearly be made aware of these different. The bypass has some long-term risks that the sleeve doesn't have, like internal hernia or bowel obstruction issues, which do not happen with the sleeve. I think coming back to the super obese patients, I think the sleeve is a good option to start with, at least in very super obese patients, because that allows us to see how compliant they are, and offer only to the most compliant patients a second stage, like a DS or SADIs, so that we don't end up with too many patients who fail to show for follow-up visit and end up with nutritional complications. I'm really worried about doing a malabsorptive procedure first, not knowing the patient very well. And even in the best series, and we have 90% follow-up, even that means that 10% of the patients do not follow up and are left somewhere in nature with their deficiencies without proper follow-up. So coming back to the bypass sleeve, clearly the sleeve is on the right now. It seems to be a simpler operation with probably lower morbidity, and this may be very important to some patients. I think I don't agree totally with John's title, everything being equal. He just showed us that it's not the case, everything is not equal. But I think provided there's no contraindication for one or the other, I totally agree that the patient can have a say in the choice.
Excellent. So I guess, you know, what I'd want to come out of this symposium, you know, is how am I as a practitioner going to really define what is the correct operation for each patient? But maybe that's not really that important for us right now, because it seems that a lot of our patients, as opposed to many specialties, we allow our patients a lot of autonomy. In other words, if the patient comes to you and says, I want a band, but they have insulin-dependent diabetes and their BMI is 70, that may not be the correct choice. And if you say no, they'll eventually find somebody who will give them this procedure, rather than having static algorithms or recommendations across the board. Lillian, Cal, how do you deal with this issue with autonomy? Certainly, we don't like to be dictators, and we can't force patients to bend to our will no matter how much we try. But at the same time, we still have to practice medicine, and I think it's an issue again with this whole idea of how much autonomy we give our patients. How do you wrestle with this?
I think that's a very good question, Kelvin. There are patients who will come quite determined to have a certain operation, even though you don't agree with them. And we do know that if we don't give it to them, they will shop around and find someone else who will give them the operation. However, I think we should also consider, in the patient's interest, that if they ask for an operation that we feel is not suitable, then I don't think we should give it to them, because it is asking for a bad outcome. And bad outcomes is what we need to prevent. We spent many years trying to bring bariatric surgery to the forefront as a legitimate operation for weight loss and metabolic disease. We don't want our colleagues and the politicians to point their fingers to us with bad outcomes. So I think as surgeons, we have a duty to advise our patient well that they should not have the wrong operation, however determined they are, whatever their reasons, because we are the experts. We can convince the patient to have the right operation.
Yes. So I'm going to ask Juan Antonio the same question, because I know his practice. A lot of people travel thousands of miles just to see you for a specific procedure. How do you tell them, I don't think so?
I agree with everybody, and it's a controversial issue, because I say again, what does the patient need and what does the patient want? This is one of the points, very, very important. But most of the patients at this moment in my practice, they want sleep hysterectomy. This is the truth. This is the truth. It's one of the reasons now in the world it's the most popular procedure. I say always, contraindication, absolutely contraindication for sleep, for example, severe acid reflux, and Barrett's esophagus. But you can do most of the time in the sleep with no problem. This is one of the points. But sometimes we have better choice. If we talk about super obese patient, well, a better choice can be to add a malabsorptive procedure. This is one of the points, but the most controversial is surgeon preference and the other point. Some groups, they perform only one procedure. If the patient goes with that doctor, we do always the same procedure. As obesity surgeons, we need to have more. We need to have more options according to what kind of patient do we have. We need to convince the patient what's better for the patients. This is the point. We need to talk about outcome, we need to talk about complication, and we need to talk about durability of the procedure. And durability of the procedure is one of the most problems that we have now when we choose the surgical procedure. But it's difficult to say, again, what does the patient want, but the most important, what does the patient need?
Okay, thank you. We have a question from the floor. The question is, when do you not do a biliary pancreatic diversion? Antonio Torres, I'm going to ask you, and John Morton, are you on still on, John?
I'm here, Kelvin.
Okay.
Yeah, you know, we only do SADIS procedure or one anastomosis DS in our 25% of our patients. We still, of course, do a sleeve gastrectomy in almost 45% of the patients at the first step of SADIS of a primary procedure. And also, we do Roux-en-Y gastric bypass. I think, you know, we reserve, you know, the malabsorptive procedure like SADIS for a very heavy patient or very metabolic patient. Or after a sleeve, if we plan one or two steps. I don't think it's going to be necessary to say that all the patients need only one surgery, because every patient has his or her own needs and his or her own clinical characteristics. We have to discuss with the patient, you know, what is the situation, and to, you know, to decide what is the best approach. But not every patient has to be submitted to a malabsorptive procedure, in my opinion. Absolutely not.
John, anything to add to that?
Well, I agree. You've got to be very careful about who you offer it to and who's doing it. As both Almino and Antonio pointed out, it really matters who the surgeon is that's doing it. It would be a wonderful world if all DSs were performed by Almino and Antonio, but that's not often the case, and it does a more technical operation that has more complication than some of the other procedures. That being said, it is the most effective when it comes to weight loss and diabetes remission. So for certain patients, I think it definitely helps. If you look at super obese, you've got to take that into context. We just looked at our big national database, MBS AQUIP, which is about 500,000 patients now, and only about 4% of those patients were super obese. So that means, you know, discussions around, you know, DS for super obese, there's still a huge majority of people that still need help in other directions, and that includes sleeve, that includes bypass, and, you know, other interventions. So we've really got to figure out how to fulfill the majority of these patients. For us in bariatric surgery, we get super interested in super obese, but there's actually a lot more people out there who need help where we need to perfect the operations we also have. One final point about revisions, you know, and the utility of using DS for revisions. Why do people not have success with a bariatric procedure? Oftentimes it's because they're not compliant, as we all know. So we're going to take potentially some of the least compliant patients and give them the operation that requires the most compliance, which is a DS. So you have to be very careful in who these patients you offer to. And what Michelle said, Suter said, was very, very important, which is not offering the procedure to patients you don't know very well. So it is important that you get to know them and they know what they're getting into. Again, I think DS is a great procedure in the right hands and in the right patients.
Thanks, John. So, Jack, welcome. We finally see you. That's good. Is your mic on?
I think so.
Okay, good. I need you. We need you to weigh in on this discussion. And I know we're running out of time, but we had some technical difficulties. But so it's a couple of things. One, it is centered around the DS. When do you not? What the issues are with calcium and these sort of things. But also, we're all intrigued by your long-term results on the sleeve gastrectomy. And I'd like your opinion on the long-term results and issues with reflux and possible Barrett's esophagus too.
Well, I think that's the major drawback of the sleeve gastrectomy procedure. We found not only a few years ago in the Annals of Surgery publication, but also in the SOAR publication, we found that as time goes by, there's more and more reflux that appears in the patients. And I would like to refer to the Prager paper that indicates that after 10 years, 15% of the patients, or 14% actually of the patients, develop Barrett's esophagus. And I think that's a scary thought. But then to perhaps along the lines of the discussion, I think that what we didn't mention too much here was the stage procedures. And I think the DS, at least in my opinion, is the best example of how you could stage a procedure, do a sleeve first, and then do the DS or SADI if you want at the later stage. Why? Because it will tell you if the patient is compliant with follow-up. When you have a sleeve patient that never shows up in the clinic, then you know that won't be a good candidate to undergo a DS. Quite the opposite is a patient that does come often to the clinic and that is really taking meds, etc. I think that would be a good candidate for a DS or a SADI procedure.
Okay, well, it's now running a little over time. We could talk about this forever. It's been a really enjoyable time for me because I've learned a lot and I've enjoyed talking to all of you. Anybody have any final comments they want to make? Any final words, John?
I was just going to say, go IFSO. This is a big achievement. So, I mean, look at how many continents are represented here, how many cases, experience. It's a big achievement. So, congrats to you, Kelvin, and to Mino and Manuel and everybody else for putting it together.
So, I echo that. Yes, Antonio.
Just to say, so important is for the rest of the world, in my opinion, this kind of proposal, this kind of things. I think, having a very outstanding experience, and I think as John is saying, going to join us a little bit more.
Yes, I think that's excellent. So if the word for IFSO is unity, this brings us all to just a little bit closer together. Despite all the technical glitches that we experienced, I think it's been quite enjoyable to have you in my office and to share with your collective knowledge throughout the world. On behalf of IFSO, I want to thank all of you for participating. Again, sorry that we couldn't get to many of the questions proposed by the audience, but we did see them, and this is new technology for me too. Between the cell phone, the different emails and things, and listening to the presentations, I find we have to multitask quite a bit. So, happy Thanksgiving, everybody. Thank you for joining in. Hopefully this will be the first of many opportunities to share our collective knowledge and to have a very nice discussion. Bye-bye, everybody.
Bye-bye.
Kelvin, outstanding work, Kelvin. Very nice.
So congratulations, Kelvin.
Bye, all of friends.
And see, Jack, I'm wearing a tie, okay?
Yeah. Extra tie. How was that?
Okay.
Bye-bye.
Spanish tie. Look, Antonio, Spanish, lower. See?
Oh, look.
All right.
Jack, because
All right. We all go back to work now. Bye-bye.
Bye-bye.
Good night, everyone. Bye.
Bye.
Bye-bye. Bye-bye.